Welcome back to Long COVID Doctor, an educational series for those of you who are still troubled with long COVID. I'm Dr. Tim Robinson, formerly a family doctor, a GP for 30 years, and now since then I've been working in Long COVID Services for 5 years. I post on all the usual podcast channels, but also on YouTube. I hope you find them helpful, and if you do, obviously click subscribe. I want to get this information out there, share these podcasts, these YouTube postings. Thanks for all the feedback you send in, the queries, the comments, really appreciate that, but apologies, I just don't have the time to respond to those queries or those concerns that you have. I read them though, and I really do appreciate them because they help me with any and all the other future postings I do. Another apology, my usual disclaimer, that's important though. Any advice or treatment I mention in these podcasts and YouTube postings should only be considered after talking to your own doctor. So, this is all about skin problems in long COVID, and I will be covering the symptoms, what you're experiencing, the conditions, the treatments, and the strategies to help. So here we go, skin problems in long COVID. Well, first question is, how common are skin problems in long COVID? Well, I'd say it's sort of quite common, judging by what I've been seeing over these last 5 years in the long COVID clinics I work in. Quite common, not very common. Often they're not volunteered. They're not the presenting symptom in our patients that are referred to our services, because the presenting symptoms are usually more concerning, having a bigger impact on their everyday life, their well-being, and more concerning. So they're not usually presented to us by the family doctors, the GPs, who refer the patients to us. But when we take a full detailed history and assessment of our patients, then quite often patients always say, oh, and also, do you know, ever since I had COVID, and now I've got long COVID, I've got these weird rashes. And they come and go, and can't understand them. Never had them before. Never had a skin problem before. So that sort of story is quite familiar to us. So yes, they're there. They're not very common, but they're certainly troublesome, alongside all the other long COVID problems. So, what are our patients actually telling us? What are their patients experiencing? What skin problems are they having? Well, they're saying that they have, say, either sort of as a whole range really, basically inflammation, sort of inflamed pink redness of the skin, sort of either flat sort of or raised sort of skin lesions, blotchiness or large pink areas, blisters, this is a common one, blisters or hives, that come and go, sort of urticaria we call it, like sort of stinging nettle rash that's, like I said, raised and moving around and itchy. The inflammation may be just sort of a dryness of the skin, dry skin, or conversely could be a weepiness, a very sort of watery weepiness of the skin, or might even progress onto sort of crustiness, almost like a scabby sort of formation on the skin in selective areas. There may not be a rash at all. It may be more of a sort of what the patient notices as a sort of general change in colour of the skin. And particularly in various areas, such as in the hands and the fingers, or only on the feet and the toes. These rashes and the blotches and the raised areas, etc., may be sort of following a symmetrical pattern. And sort of, both arms, for example, both legs, both feet. Or it may be completely random, completely sort of no pattern at all, sort of here, there and everywhere. So basically it's such a broad range of different skin presentations. Along with the actual appearance of what is seen on the skin, the patients describe various feelings and what they have along with their rashes and blotchiness, etc. And that is itchiness. This is very common. Either small areas of itchiness dotted around here, there, everywhere, or just generally. And that itchiness might be worse with the warmth. It may be worse with water, so particularly, say, in a hot shower or a hot bath. Better with cooling, so they find themselves putting their sort of itchy fingers, itchy feet in a basin of cold water to soothe them. Patients describe burning and stinging and pricking sensations, or pins and needles. Basically, again, a whole range of different feelings associated with the rashes. Or this itchiness, it might be occurring without any rash at all. There may be just this, and likewise pins and needles. There's not anything to show for it. It's just they're experiencing this cutaneous, this skin irritation and itchiness and pins and needles, as I say. So along with all these rashes, in our long COVID patients, a number of those patients already previously, prior to their COVID, had skin conditions. And now, with their long COVID, since they're a COVID infection, now they've got long COVID, they're actually saying that those conditions are worse. So eczema, classic atopic eczema, is basically now, having had their COVID, is very much out of control. Likewise, psoriasis and rosacea and seborrheic dermatitis, that's sort of that annoying flakiness of the scalp, dandruff, is all very much worse. Or worsening of their cold sores. They're having many more cold sores. So those are previous conditions that have been flared up since having their long COVID. But also new conditions, and the classic one, and in a way sort of related to the last one I mentioned, the herpes cold sores, is shingles. So we're definitely seeing more patients with shingles since they've had their long COVID. So that's what the patients are experiencing. That's what they're telling us now, when we've sort of taken that detailed history and assessment. So what are we going to do about it? So what should you do about it? Well, basically, any new condition, long COVID or whatever, even if you don't have long COVID, any new condition, it's reasonable, especially if it's having an effect on you and your lifestyle, etc. It's reasonable and it's right for you to go along to your doctor and ask for advice. Obviously, let's not just be COVID blind here, or because you've had COVID and you've got this condition, let's not just put it down to COVID. It might be completely unrelated. So your eczema, even though it's still eczema, you had eczema prior to long COVID, you've now got worsening eczema. That's the reason why it's worse. So, it is, but the problem, the underlying fundamental problem is that you do have eczema. So you go along to the doctor and you basically, the doctor will do what doctors do, and that is quiz you and examine you and ask you all those questions. How long have you had it? What makes it better? What makes it worse? What's it like? What are you experiencing? And a thorough history and examination is so important. There may be some blood tests, but obviously in the long COVID context, you're going to have blood tests done anyway, aren't you? You're going to be looking, we need a full blood picture, we need liver function tests, we need kidney function tests, we need thyroid, make sure that you're not diabetic, and sort of all those allied tests we do, looking for inflammatory markers, etc. So, investigations. Not really any investigations for skin problems. Any red flags? Well, in this context, really, no red flags. But, basically we've got to be thorough and just go through that mental process of being, like I said, thorough in the history examination and assessing the symptoms, signs, and getting a diagnosis. Because when you've got a diagnosis, you can set about putting it right. Set up a plan, a strategy. So let's look at in depth the causes for skin problems and how we're going to treat them. When we think about long COVID, we think about the causes of long COVID in general, don't we? We think about that excessive inflammation, the excessive inflammatory response. And the reason for that, of course, is the abnormal innate immune system response. And part of that, remember, part of that is the excessive cytokines, the inflammatory, pro-inflammatory mediators, factors that kick off this inflammation. But the other big one in the innate immune system is activation of the mast cells. Mast cell activation syndrome. So basically, you've, I'm sure, heard of MCAS, mast cell activation syndrome. There's a whole podcast, YouTube on this. I've just done an update of MCAS as well, which is probably worth listening to. But this is the skin condition that, this is why I'm mentioning it first, this is the skin condition that brings us most problems in our long COVID clinics. This is the most frequent of the skin problems in our long COVID world. So remember well, first of all, how's it presenting? Basically, it presents with hives, urticaria, what we call solar dermatitis, so irritation of the skin with sun, so photosensitivity, but hives. What are hives? Basically, hives are those raised bumps, pink raised bumps, which are really itchy, and they can be anywhere. They can be generalized, or they can be in little patches, and they classically sort of come and go. So they arrive, they arrive up here, and then they settle down after a few hours. The commonest cause for urticaria or hives is a viral trigger. Well, COVID is a virus, and so it's no surprise that COVID creates this, along with all those other things that dear old COVID does. And then it sort of hangs around in our long COVID world. So basically, that's how mast cell activation is presenting in our long COVID patients. Just a quick reminder, what is mast cell activation? Well, what are mast cells? Basically, mast cells are little cells that are sitting throughout all the tissues in the body, but in particular the skin, the gut, and the upper respiratory tract. Okay, this is because these mast cells are part of the innate immune system, that first defense for the outer world, and our barrier, our immune barrier, if you like, defending us. And when they're activated, they release these chemicals that initiate inflammatory response. lots of chemicals, but the one that is released more than any other is histamine. Okay. The function is, as I say, just to activate the immune system to attack the invading virus or bacteria or any of those foreign antigens. Mast cell activation, as I said, because mast cells are most densely concentrated in the skin, the gut and the upper respiratory. So when there's mast cell activation, you're going to have activation of those other areas. So upper respiratory tract. So you're going to have runny nose, you're going to have a postnasal drip, you're going to have sinus congestion, and often a sore throat because all that area is pretty inflamed. And likewise the gut. The gut in mast cell activation kicks off with loose motions and sort of colicky abdominal pains and bloating and new food intolerances. So how do we treat mast cell activation? Again, listen to the podcast on that, but basically very briefly with a H1 blocker and an H2 blocker. H standing for histamine, so histamine 1 blocker are our good old antihistamines. So cetirizine, fexofenadine, loratadine. You can buy these over the counter. And so cetirizine, which there was a study show that actually this is the strongest of the antihistamines. So 10 milligrams, it says on the box. In mast cell activation, we usually need to double the dose, and likewise the fexofenadine, and likewise the loratadine. So that's H1 blockers. We also need H2 blockers. H2 blocker that is used is famotidine, 20 milligrams. Start with once a day, but like with the H1 blockers, you probably need, and you can have 20 milligrams twice a day. So in a way, that's the best treatment is to take tablets for mast cell activation. But this is a skin problem, isn't it? And so yes, you may know, and you probably do know, that you can have topical, so antihistamines in creams. Yes, it seems logical if you've got a skin problem because of this mast cell activation, use a cream. Don't want to take tablets if you don't have to. Yeah, true, get that. However, creams are not as effective as tablets. And actually, and if you think about it, it's better to give a tablet that's actually going to be absorbed and going to go to those mast cells in the tissues, rather than creams, which are, yes, they are absorbed and go into the tissues, but the absorption is not going to be as good and the concentration of those antihistamines are not going to be as good in using a cream compared with a tablet. That's my personal view. So that's excessive inflammation bringing about sort of initiation of the innate triggering off and activation of the innate immune system, mast cell activation. But the adaptive immune system is also part of this whole skin problem in long COVID patients. So the adaptive immune system sort of destabilizes the connective tissues within the skin and also initiates the production of autoantibodies, those antibodies that attack our normal tissues. There are no real treatments for those. Yes, there's some hypothetical treatments, but no real treatments that are accepted and used in everyday treatment of long COVID for this. Unfortunately, they do contribute to that excessive inflammation in the skin, which manifests with all those sort of the redness or itchiness, etc., etc. Other causes in long COVID of skin problems? Well, again, remembering one of the other common causes of dysautonomia across the board in long COVID is dysautonomia. So dysfunction of the autonomic nervous system. And in the skin part of dysautonomia, the blood vessels are affected by this dysautonomic process. And the blood vessels, the little mini blood vessels, the minute blood vessels, the arterioles, venules, and the capillary bed is affected. And they become either overactive or underactive. So they don't respond normally to the sort of the normal demands that are needed. So therefore the blood flow to the surface is either excessive or compromised. That leads to a condition called acrocyanosis, which is when the sort of patients who have dysautonomia notice that their feet and toes go purple, and it's like Raynaud's condition, which again is commoner in long COVID patients. It's to do with this dysautonomia. You may have heard of COVID toe, dear old COVID toe, which was quite common it was not uncommon, let's say, in acute COVID, and it made the news because it was so weird. Just one single toe would suddenly turn purple and be really itchy, like having single toe having cold chilblains over the whole toe. This is due to dysautonomia, but also due to many blood clots, the microthrombi, which again we know is part of long COVID, as well as damage of the nerves actually in serving the blood vessels in the peripheries. And those damage of those nerves is small fiber neuropathy. And that can happen anywhere. And again, it's a common problem in long COVID due to, as I say, this inflammation and mini blood clots and autoimmune problems. And patients tell us about, their skin feels like prickly and needles and burning and hypersensitive and tingling or crawling sensations. All these symptoms are symptoms of small fiber neuropathy, which, again, is a strange condition. There's no real treatment to repair those little nerve fibers. They regrow in their own time. So they do. That's what we see. Peripheral nerves regrow. Part of a neuroplasticity phenomena. But so in the meantime, there are various tablets, pills, medications that you can have prescribed for you if those sensations, that tingling or that burning, or those needles or that crawling sensations are really unbearable. So there are various drugs, something called an SNRI, to sort of modulate pain perception. And then there are the gabapentinoids, which serve to dampen down that excitation of nerve fibers and neuropathic pain. So that's small print, really, but there are treatments. The take-home message is there are treatments for those type of symptoms. I think, just as a sort of an aside, any medication really start low, go slow, because as we know in long COVID, sensitivity to medication is extreme. So we've covered the inflammatory causes for skin problems in long COVID. We've covered the dysautonomic causes. What about sort of other sort of things such as viral reactivation? Again, we know about this in long COVID. Again, it is thought to be one of the factors in responsible for long COVID and for perpetuating inflammation. Viral reactivation, that is latent viruses from previous infections, that are lying in our tissues dormant and held under control by our immune system. Right. But as we know, in long COVID, the immune system is not as efficient as it should do. So a poor and inefficient, suboptimal immune system, if you've got that, it's more likely that those latent, dormant viruses can, if you like, wake up, re-emerge, represent themselves and become a problem. Okay? And examples of this obviously are shingles. Again, we're seeing, the incidence of shingles certainly went up during acute COVID phase, but also during long COVID. We've had a number of patients say, ever since I've had COVID, I've had a number of attacks of shingles and I've got recurrent shingles. Well, it's not very common, but certainly we see it in long COVID. Likewise, so the treatment for that, of course, shingles outbreak, episode of shingles, it's off to the doctor for a course of what we call acyclovir, the antivirus tablets. So 5 times a day, or there's a newer one called valacyclovir, which is only 3 times a day. It's more convenient, 1,000 milligrams, 3 times a day. Valacyclovir. So in the same herpes families, so basically shingles is herpes zoster virus. So other herpes viruses that can lay dormant and then be reactivated when your immune system's been compromised. Examples are cold sores, so herpes viruses, so cold sores on the lips, genital herpes. Again, we have had patients with recurring, ever since I've had my long COVID, they say, I've had terrible, cold sores on my lips or the genital herpes. They just keep coming back. It's terrible. Again, go along to your doctor. Don't just put up with it. Don't just apply the acyclovir cream, which you can buy from the chemist. Yes, it's much more effective to have acyclovir tablets, or the other one I mentioned, the valacyclovir, because like I said, it's more convenient. And genital herpes, if you're unlucky to have that on a recurrent basis, then you really ought to be on a preventative tablet on a twice daily basis. So you can have acyclovir, 400 milligrams, twice daily on an ongoing basis. I mean, no one wants to take pills if they don't have to, but if it's going to prevent you having an outbreak of genital herpes on a monthly basis, yes, monthly basis, a lot of women may have that triggered with their period, their menstrual cycle, you'd want to take them, wouldn't you? So, what about other causes of skin problems of long COVID? Well, remember what I said earlier on? What about those patients who've had previous inflammations? So eczema, seborrheic dermatitis, psoriasis, rosacea. Well, yes, they are patients who are saying to us, well, ever since I've had my long COVID, my eczema's gone crazy, or psoriasis is just out of control. So take those conditions along to the doctor. They need to be addressed. So eczema, you're going to need those hydrating creams, those emollients, E45, aqueous cream, just to put the moisture back into the skin. And you're going to probably need a steroid cream. May be high dose, say like Betnovate or even maybe Dermavate initially, and then ramp it down, not ramp it up, ratchet it down to lower potency hydrocortisone just to bring the eczema under control. Seborrheic dermatitis, that sort of flakiness of the scalp or on the face or along the hairline, again, that is so easy to treat with Nizoral ketoconazole lotion. Rosacea, that sort of red rash on your cheeks, butterfly distribution. So you need a course of tetracycline, doxycycline tablets, or metronidazole cream, just to bring it under control. And likewise, psoriasis. Yes, psoriasis, if your psoriasis got out of control because of your long COVID, you need to have, sort of either steroids or calcipotriol, Dovanex, just to dampen it down, or more severe psoriasis, you're going to need immunosuppressants. It's off to the dermatologist, basically. Off to the dermatologist for immunosuppressants or biologics, which are basically cytokine inhibitors. And we know about cytokines in long COVID, don't we? Cytokine storm, etc. Anyway, so those pre-existing, pre-COVID conditions, skin conditions that you have that have got out of control, take them to the doctor. They need to be addressed. Before I wrap it up, just a couple of others that we need to mention. Skin-related problems in long COVID. Again, the first was hair loss. Again, we heard this very often in the early days of acute COVID, the consequences of having COVID. And so those patients who then became long COVID patients, not better within 3 months, 12 weeks, part of their problem was, and also my hair's falling out. I'm going bald. Help. Which is a bit alarming, especially for the lady folk. Absolutely. So basically, hair loss was common in long COVID. And it's not uncommon, so we have a few of those patients telling us about their hair loss still. It's got a fancy name, sort of telogen effluvium. And basically, it happens because hair doesn't grow continuously. Because we've got a lot of hair on our head, it looks like it all grows continuously, but hair follicles go through cycles. There's the growing phase, and then there's the slowing down phase, then there's the resting phase. It takes about 6 months for that cycle, for one individual follicle to go through, 6 months. And then when it gets to the end of that cycle, it goes into the growing phase again, followed by the slowing phase, followed by the resting phase. With an infection, an acute viral infection, so acute COVID infection, that puts the hair follicles into the resting phase. It just basically stops the growing and just stops the slow growth, the growing phase, the slow growth phase, puts all the hair into resting phase. And in the resting phase, that's when hair falls out. So, like I said, it's a 6-month cycle. So actually, I think we're seeing less of this hair falling out as time's gone by, because I think the acute infection was the thing that kicked it off, and it's not the long COVID that is keeping people losing hair. So in other words, I think that now yes, there are still acute infections around, definitely, but it's not the really aggressive, severe, wild type or alpha, beta, delta variants that were really aggressive and caused a major sort of impact on cells throughout the body. So basically, I think it's peace of mind we're trying to put across here, and that is, it's going to get better because the hair follicles will wake up and, get back into normal, sort of the cycle, the 6-month cycle. Finally, the other condition since COVID we're seeing more of are connective tissue conditions. So there are a couple of them. One is scleroderma, which is a complicated autoimmune condition, and it affects lots of different tissues in the body. But with regard to the skin, as this is a skin posting, so with scleroderma, there comes Raynaud's phenomenon. This is the turning of parts of the fingers, classically white into blue and then into crimson, going through those sort of colours, different colours of the rainbow. And the skin is itchy and dry because of reduced sweat production, and it's less oily, and it leads to thickening and pigmentation. So scleroderma, it's a rare one, it's an autoimmune thing, but we're definitely seeing this in patients. We're also seeing it, so scleroderma patients, just as an aside, is one of the causes for problems with the swallow, because it causes, like I said, it can cause lots of problems throughout the body, but the connective tissues in the upper esophagus can cause problems with swallow. So a lot of speech therapists are saying that we're seeing more scleroderma now. The other connective tissue problem that is seems to be more coming to our attention is hypermobility, joint hypermobility, and this condition of Ehlers-Danlos syndrome, which is basically a hypermobility condition with the diagnosis. There are lots of variations of Ehlers-Danlos syndrome, but essentially it's a problem with connective tissue disorder. It's a genetic problem, and it leads to skin. We're focusing on the skin here. So skin fragility and hyperextensibility, easy bruising and poor healing. So again, like I said, we do see quite a few patients with long COVID, and then we do find that, oh, you're very hypermobile. That's very interesting. There's an association there. Or put it another way, if you've got hypermobility, Ehlers-Danlos syndrome in particular, you're probably more likely to have long COVID. It's a risk factor. So those are the various conditions, and I've sort of given a quick sort of told you about the treatments that should be used for them. But is there anything else we can do, is really what we're asking. And in a way, yes, I think we've got to, at the same time, remembering what we're dealing with here. We're dealing with one of the manifestations of long COVID. Okay, what about all the other manifestations? What about the whole of long COVID? How are we dealing with long COVID? I think we've got to remember the bigger picture here. So we've got to be helping with the fatigue. We've got to be using the 3 Ps, the planning, the prioritizing, and the pacing to control fatigue. We've got to be thinking about gentle reconditioning, stretching those ligaments, those tendons, those muscles, waking them up, maybe with some yoga. We've got to be thinking of focus and try and sort of combat stress, etc. Just to calm things, maybe some mindfulness. Very helpful. We've got to be focusing on sleep. We've got to be thinking about, how are we going to get best restorative sleep? So sleep hygiene. And then, of course, my favourite is diet. That mixed balanced diet to give you all those building blocks for recovery, for repair of those tissues, and for those natural anti-inflammatory polyphenols, as well as the nourishing prebiotic fibre for the microbiota. So, like I'm saying, I think we've got to take the bigger picture. Not only focus on the skin, the superficial, the cutaneous side of it, the creams, the tablets, etc., we've also got to be thinking of long COVID in general. So there we are. That's my update on skin problems in long COVID. I hope you found it helpful. As I said at the start, this is an educational series for you long COVID sufferers. And I do hope, sincerely hope, that you're finding them helpful and they empower you and upskill you and give you knowledge of the conditions, the causes, and how best to go about treating them. Remember my usual disclaimer: anything I've mentioned, any of the advice, the treatments I've mentioned, just talk to your doctor first before you try them, all right? Remember, safety first, my mantra. So, if you have found them helpful, this podcast and all the other ones I've done a few now, click subscribe, as they say on YouTube. Click subscribe is a bit of a cliche now, isn't it? But why do I want to do that? I want to do it for one reason, and that is to help as many people as possible. I'm not doing it for any other reason. I'm not benefiting myself in any other way. There's no advertising, no advertisements, no monetization. Like I said, I want to spread the word. Keep the feedback coming in, your comments. Yeah, I'm sorry, I can't respond to your queries. I wish I could. There's only one of me, and I'm spread pretty thinly as it is. So I just haven't got the time to respond to those comments and those suggestions and certainly the queries. I wish I could. But keep them coming, because they do help me with my posts and they give me some steerage, which is good. So in the meantime, I wish you well with your long COVID recovery. All the very best. Cheerio now. Goodbye.